ligaments of urinary bladder. So you divide the ligaments as true ligaments and false ligaments. So the main difference is this true ligaments is actually the condensation of pelvic fascia. But this false ligaments, they are actually folds or the peritoneal folds which produces the false ligaments. So true ligaments means they are true. They are produced by the condensation of pelvic fascia, but false ligaments are just peritoneal folds. So now we'll look at the true ligaments. So all the true ligaments, out of that only one is developmental. One developmental means the only one that is developmental is median umbilical ligament. The median umbilical ligament getting attached from the apex, which is a remnant of urachus or allantois. Rest all other ligaments are considered as condensation of pelvic fascia. So how many ligaments are there? You find the developmental one, median umbilical ligament, that is a remnant of allantois or urachus. And then you find 4 puboprostatic ligaments in males and 4 pubovesical ligaments in females. So 4 puboprostatic. 4 puboprostatic means out of this they are 2 medial and 2 lateral. Okay. So total 4 puboprostatic ligaments in males and 4 pubovesical in females. Then you find 2 lateral ligaments and then you find 2 posterior ligaments. So these are the different true ligaments. So total 9 ligaments are there. 8 condensation of pelvic fascia, 1 developmental. So look at that figure. This is the bladder. So this is your urinary bladder. This is the pubic symphysis anterior. Now I am talking about the different true ligaments. So you see these 4. These are the puboprostatic ligaments. Okay. So puboprostatic in the case of females, the pubovesical, they are the same. Puboprostatic and pubovesical in the case of females. So this puboprostatic ligaments will extend from the neck of the bladder anteriorly to the pubic symphysis. Look at that, that is a pubic symphysis. So I've already told you out of 4 you find 2 medial ligaments and then 2 lateral ligaments. So this medial puboprostatic ligament will extend from the neck of the bladder towards the pubic symphysis, and lateral ligament will again extend from the neck towards the tendinous arch of the fascia there. Okay, so these are the 4 ligaments, puboprostatic in the case of males and the pubovesical in the case of females. And then you find 2 lateral ligaments. These are the 2 lateral ligaments, and these 2 lateral ligaments will extend from the infrolateral surface to the lateral pelvic wall. Okay, and then you find the posterior ligaments. These are the 2 posterior ligaments extending from the base of the bladder towards the posterior part, and one feature is that it is this posterior ligaments which enclose the vesical venous plexus. So these are the total 8 plus 1, 9 ligaments you find, true ligaments you find for the bladder. Now we come to the false ligaments, and I've already told you these false ligaments are actually peritoneal folds. The median umbilical fold, that peritoneal fold that is overlying the median ligament. Then still lateral to that you find the medial umbilical fold. That medial umbilical fold is actually overlying the obliterated umbilical artery. Then you find on either side lateral folds, lateral peritoneal folds going on towards the lateral pelvic wall. Still posteriorly you find the posterior peritoneal folds that is proceeding on from the bladder towards the sacrum. So all these are peritoneal folds. So you get a median fold, a medial fold, a lateral fold, and a posterior fold. So with that we finish the support of the main structures that's supporting the ligaments that is concerned with urinary bladder. So now we are coming to the interior of urinary bladder. So when you view the interior of bladder, you find it is characterized by the presence of temporary folds and rugae. Once distension occurs, it disappears. And one characteristic feature you find in the interior of bladder is the presence of internal trigone. So internal trigone is the smooth surface which you find very close to the dorsal wall or the posterior wall of the bladder. So that is what is termed as internal trigone. I've already mentioned in the earlier session trigone. Remember that very close to the base of the bladder there was an external trigone, and in relation to the interior you find a smooth region in the dorsal wall or posterior wall termed as the internal trigone. So this is the view of the internal trigone. So this is the view of the bladder, interior of bladder. You find the whole other region has got rugae, but this region, look at this triangular region that is present on the posterior surface of the bladder. This region is what is termed as the internal trigone. So you find this trigone, internal trigone is roughly triangular in shape. So this is the apex, this is the base, and these are the other two angles, other two borders you find for the trigone. So what you see there is, you find the two ureters opening on towards this angle. The two ureters will be opening there, and the urethra begins from this region. So now it's very easy to say the borders. So one border above, this is the border above, this is formed by the interureteric ridge. That ridge between the two ureter, the ureter opening here, the other one here. So this is the interureteric ridge, otherwise termed as the bar of Mercier, Mercier's bar. So this is the interureteric ridge, otherwise termed as the Mercier's bar. On either side here, you find the next two ridge. What do you call that ridge? That is the uretero-urethral ridge. So from the ureter towards the urethra. So what do you call it? Uretero-urethral ridge, otherwise termed as the Bell's bar. Okay. And this here, this region, that is the apex, that will be corresponding to internal urethral sphincter. Let me attest there. So read that. The apex is formed by the internal urethral orifice. The base is formed by the interureteric ridge, otherwise termed as the Mercier's ridge. And on either side you find the uretero-urethral ridge. And what is the thing that is so important about the internal trigone is, it is the most sensitive part of the bladder and it is highly vascular. And in relation to the development, you should remember this internal trigone is a part that is derived from mesoderm. Okay, it's actually derived from the absorbed mesonephric duct that we'll discuss later. So it is derived from mesoderm and it is exclusively sensitive. It is rich, high vascular and sensitive. And one more thing is there, this mucosa in the internal trigone will be very much attached to the muscular wall. Why? Because the intervening submucosa will be absent. So this much feature you should say, you should know, remember about internal trigone. So one more thing in the case of males that you should remember is a terminology termed as uvula vesica. So what is this? This is the apex of the trigone, that is the internal urethral sphincter. So very close to the internal urethral sphincter, what happens is, this is the prostate. I told you it is resting. This in urethra, internal urethral sphincter is very closely related to prostate. And one lobe of the prostate, this is the median lobe of the prostate. So in certain case, this median lobe of the prostate will be enlarged and it will be projecting on towards this region of the trigone, producing an elevation there, and that is what is termed as uvula vesica. So actually it is an enlargement of the median lobe of the prostate, producing an elevation there very close to the trigone. So with that we finish the interior of the bladder. So now you should know the main arteries supplying the bladder. The main arteries are superior vesical artery, inferior vesical artery, obturator artery, and also inferior gluteal artery. And in female, you get contributions coming from uterine artery, also supplies it. So these are the main arteries supplying urinary bladder. Okay. In females, this inferior vesical artery will be replaced. Superior vesical, obturator artery, uterine artery, inferior vesical replaced by vaginal artery. So now we come to the venous drainage of the bladder. So the main venous drainage is to the vesical venous plexus. So this vesical venous plexus is actually present very close to the infralateral surface. So from there, this vesical plexus will be passing through the posterior ligament. Remember that relation I mentioned before when posterior ligaments were taken? Okay. So then it passes through the posterior or very close to the posterior ligaments and finally drains into the internal iliac vein. And one thing that you should remember is this vesical venous plexus has got a communication with prostatic venous plexus also. Okay, so that is the main venous drainage you find for the urinary bladder. Lymphatic drainage, draining mainly into external iliac nodes, and some also drains into the internal iliac nodes. So now we come to the nerve supply of the bladder. So nerve supply, when you're thinking about the nerve supply, always remember the bladder has got a normal micturition reflex. Okay. So you divide the nerve supply as sympathetic and parasympathetic innervation. So always remember, sympathetic innervation to the bladder comes from T11 to L2 segments. Sympathetic is thoracolumbar in outflow. So it is coming from T11 to L2, and these preganglionic fibers will come and relay in the inferior hypogastric plexus. From there you get the postganglionic fibers which go and supply the bladder. And one thing is, this sympathetic is actually inhibiting the detrusor muscle but stimulating the sphincter vesica. So once it is inhibiting the detrusor muscle, this sympathetic outflow, it is inhibiting detrusor. That's the main muscle you find in the wall of the bladder. So what happens? Sympathetic innervation is mainly responsible for filling of bladder, or in other words, it is described as nerve of filling of bladder. And parasympathetic. Parasympathetic is actually coming from S2, S3 and S4 through pelvic splanchnic nerves termed as the nervae erigendis. Okay. So parasympathetic means it is the nerve of emptying or voiding. Always remember like that. Parasympathetic is responsible for emptying or voiding. Why? How? That is because this S2, S3, S4 will act as motor to detrusor, causes contraction of the detrusor with relaxation of the internal sphincter. So parasympathetic is the nerve of emptying, as well as sympathetic is the nerve of filling. So for the normal micturition to act, you get a normal micturition reflex at that spinal cord level. And this normal micturition reflex will be controlled from the cortex by a cortical center that is present very close to the paracentral lobule. So once there is abnormality in the micturition reflex, you get different types of bladder presenting. Once this cortical control is lost, you get other abnormalities also affecting the bladder. So look at that. These are the different things. This is the sympathetic outflow from T11 to L2. coming, relaying in the hypogastric plexus. From there, the postganglionic fibers going and supplying the detrusor muscle. Look at that. It is negative. It's marked as negative on detrusor muscle. So it's a filling. The other part, it is the parasympathetic. The parasympathetic supplying from S2, S3 and S4 pelvic splanchnic nerves. And you find it is causing contraction of the detrusor but inhibiting the sphincter. So causing contraction plus inhibiting the sphincter. Then you find the pain sensation or stretched sensation from the bladder is also being carried by the same route. So with that we finish the nerve supply of the bladder, and now we come to the last part, applied anatomy. So what are the things you should know? Different types of injuries will be presented. It can be intraperitoneal injuries or extraperitoneal injuries. So if it is an intraperitoneal injury, this usually happens in an injury if it is affecting the superior surface. Why? Because the superior surface is very well covered with peritoneum. Suppose you get an injury there, that often lead to an intraperitoneal injury, and you get urine and blood in the peritoneal cavity. But if it is an extraperitoneal injury, commonly in the case of fracture pelvis, where the injury is below the peritoneal reflection, it also presents with different types like abdominal pain, hematuria, like that. So injury can be intraperitoneal or extraperitoneal depending upon the site of injury. Next one is retention. Retention of urine can occur if there is obstruction to urethra. If urethral obstruction is there, what happens? It is not possible for urine to pass out. Commonly occurs in the case of benign prostatic hypertrophy or malignant enlargement of the prostate compressing the urethra, thereby obstructing it. And in certain cases, such an obstruction or retention can further lead to hydroureter. It can further lead to hydronephrosis. Next one is cystitis. So what is the cystitis? Is the inflammation of the bladder is what is termed as cystitis. It causes an increased frequency and urgency of micturition, and the patient can present with a suprapubic discomfort, and you find the urine will be cloudy and offensive. Next is carcinoma. The common carcinoma is urinary bladder carcinoma is very typically seen in aniline dye workers. That is one of the very common presentation. Carcinoma of urinary bladder, that's a transitional cell carcinoma. It is more common in aniline dye workers because of a chemical cause. Then different types of spinal cord injuries also present with different abnormalities or different bladder. So first type that you should be familiar with is automatic bladder. So what happens is, what is this automatic bladder? I have told you at the spinal cord level, that is at the level of S2, S3, S4, you find a normal micturition reflex is there. This micturition reflex at the spinal level is being controlled by the paracentral lobule of the cortex. So what happens is, if the spinal cord injury occurs above the spinal micturition center, then you get the automatic bladder. So in such a case, this cortical control will be lost and the bladder fills and empties in every 1 to 4 hours. So that is the automatic bladder. Next is autonomous bladder. So what is this autonomous bladder is, if there is destruction of the spinal segments, that is S2 to S4 spinal segments of the spinal cord. If that region, some abnormality occurs at that region, then what happens is voluntary and reflex control of micturition will be lost, and then what happens, this bladder overfills. First it fills, then overfills, and then starts overflowing. So that type of the bladder where you get a defect at the spinal cord level of S2, S3, S4, that is what is termed as autonomous bladder. So in autonomous bladder you get overfilling and overflowing. But in the case of the other one, where the cortical control was lost, the normal micturition or the bladder will fill and empty in every 1 to 4 hours. So these two, automatic bladder and autonomous bladder, are the two abnormalities that you should be aware of. So now we come to the last part, development of bladder. So you know the trilaminar disc. And now what happens to the trilaminar disc? You have got the folding coming, and then you have the development of foregut, midgut and hindgut. It's already been taken. Do you remember that? After the folding you have got the foregut, midgut and hindgut. And what happens is, from the hindgut, as a result of the folding, you find this allantois now comes as the diverticulum from hindgut. Remember that? Dividing this allantois will divide the hindgut into pre-allantoic part and post-allantoic part. Okay. So now what happens? This is the hindgut and this is the allantois, which is now a part of the hindgut. So now what happens? This hindgut is now, or the cloaca, this region is termed as the cloaca, and this cloaca is now divided by a septum here. Look at that, the septum here. That septum is what is termed as urorectal septum. So look at that. This urorectal septum will divide the cloaca into an anterior part and a posterior part. So this anterior part is what is termed as primitive urogenital sinus. Okay. And the posterior part is what is termed as primitive rectum. So urorectal septum will divide this cloaca into an anterior part termed as the urogenital sinus and a posterior part termed as the primitive rectum. Now what happens? Into that urogenital sinus, look at that, into this urogenital sinus you have the opening of the mesonephric. Look at that. Into that you find the mesonephric duct is opening. So this mesonephric duct, which is opening into this urogenital sinus, will divide this urogenital sinus into two. This is what is termed as vesico-urethral canal. Vesico-urethral canal and a definite urogenital sinus. So look at that. The opening of the mesonephric duct divides the primitive urogenital sinus into two parts termed as the vesico-urethral part and a definitive urogenital sinus. So now look at that figure. You find the cloaca divided by a urorectal septum into a urogenital sinus and a primitive rectum. Into this urogenital sinus you find the mesonephric duct is opening, which divides it into vesico-urethral canal and a definitive urogenital sinus. It is into this vesico-urethral canal. This vesico-urethral canal is concerned with the development of bladder. So look at that. This is the urogenital sinus. Into that you have already studied this mesonephric duct. When kidney was taken, do you remember that? This mesonephric duct will come and open into this urogenital sinus, and from there you have got this mesonephric duct will show small diverticulum. Do you remember that? That is what is termed as ureteric bud. That ureteric bud is going on towards the metanephros, and this part is, that is how you find the kidney developing, this ureter developing, all those things happening. Fine. So look at that. This mesonephric duct is coming and opening into the urogenital sinus, dividing into two parts. Now what happens is, this much part of the mesonephric duct is absorbed. Look at that. This mesonephric duct gets absorbed, and this absorbed mesonephric duct is actually forming the internal trigone. So once this part gets absorbed, then you find the two ureters, ureteric bud is on the other side. So what happens? The two ureters opening on the internal trigone, and the lower part you find the urethra starting. So that is how you get the internal trigone from this absorbed mesonephric duct. So the development of urinary bladder, the entire mucosa except trigone develops from the endoderm of vesico-urethral part. Okay, so the whole of the mucosa develops from the endoderm of the vesico-urethral part. You already know what is this vesico-urethral part. That is that mesonephric duct dividing the urogenital sinus into vesico-urethral part and a definitive urogenital sinus. So the whole of the mucosa except trigone will develop from the endoderm of the vesico-urethral part. And this internal trigone region will be developing from the absorbed part of the mesonephric duct. So internal trigone from the mesoderm by the incorporation of the caudal part of the mesonephric duct. The apex of the bladder is from the proximal part of allantois. Do you remember that allantois? From the proximal part, you find the apex of the bladder is developing, and the whole of the musculature of the bladder develops from the splanchnopleuric layer of lateral plate mesoderm. So that much about the development you can remember. The whole of the mucosa derived from the vesico-urethral part, trigone developed from the absorbed mesonephric duct, the apex derived from the proximal part of the allantois, the musculature derived from the lateral plate, that's splanchnopleuric layer of the lateral plate mesoderm. So now you know the development of urinary bladder. So now we come to the anomalies. If there is an incomplete urorectal septum, do you remember that urorectal septum? Okay. So if there is a defective urorectal septum, it can lead to a fistula, and that is what is termed as congenital rectovesical fistula. Okay. If this urorectal septum is not completely developed, it can cause abnormal communication between the rectum and the vesica. So that is what is termed as rectovesical fistula. Then you come to the urachal cyst. So what is that? Is this intermediate part of the allantois becomes patent. The proximal part and the distal part of the allantois will disappear or obliterate, but the intermediate part will persist, and that will lead to a midline swelling in the infraumbilical region, and that is what is termed as urachal cyst. So this is the apex. From there, what happens is the proximal part will degenerate, the distal part will degenerate, the intermediate part will present as a cyst there, and that is the urachal cyst. If the whole of that part, entire allantois, becomes patent, then that is what is termed as urachal fistula. Then what happens? The urine will compound through the umbilicus. Okay, and that is usually associated with different structural or congenital strictures of the urethra. Look at that, the whole of the part, allantois, is patent. Then you find the urine will come out through the umbilicus. Last one is ectopic vesica. So ectopic vesica means if the infraumbilical part of the anterior abdominal wall is deficient, and then what happens? This interior of bladder will be exposed. That condition is what is termed as ectopic vesica. So with that, we finish the development and the different anomalies of bladder. So I think now we are familiar with the different parts of the bladder. So first of all, in relation to the bladder, you should know where the bladder is located, and then what are the different parts of the bladder, the important relations of each part. Then what are the ligaments you find? False ligaments, true ligaments are there. Then you should know about arterial supply, venous drainage, lymphatic drainage, and finally the nerve supply. How does parasympathetic and sympathetic acts? What is the normal micturition reflex? Cortex controls it, like that, and some applied aspects. And finally the development of the bladder with some anomalies. So I think with that I'll conclude the topic. Go through the topic, learn it, and it is one of the common topic you get for your exam. So study well, go through the different diagrams you find in the textbook, read them and study. So let me stop here. Okay, thank you.